C3GP, C3 glomerulopathy is not that new entity. Basically, it is surfaced since 2007, then by the international conference and consensus statement about it in London, in the Oxford, and then it came out in the human knowledge. Now it is far vastly expanding. Basically, MPGN, membranoproliferative gene, we called it, C3GP is being labeled as such, and membranoproliferative gene, basically it is a pattern of glomerular injury and histology. C3GP is also a predominantly MPGN histological disease, so it is a dominant or 2+ C3 deposition compared to the other immune complex deposition, and because of the continuous complement activation or dysregulation in alternative complement pathway. So idiopathic MPGN, mesangial proliferative GN, necrotizing and crescentic GN. These are and also proliferative and exudative GN is also can be the underlying histology of C3GP. By far, the commonest is MPGN, and presentation is GN like hematuria, proteinuria, hypertension, azotemia, edema, and your CKD, AKI, and other visual features of the GN. And the histologically it is of two types. Dense deposit disease type 2 is notorious one, difficult to treat, and then C3GN, the C3 glomerulonephritis, the type 1, around 75% or so, and little bit of responsive subendothelial deposition and mesangial deposition predominantly. Can be there other place deposition is possible. So how to treat these cases, and diagnosis is obvious. Diagnosis is by the your histological diagnosis, as it says the dominant 2+ C3 deposition on electron microscopy and immunofluorescence, and plus exclusion of the other differentials in histologically. And treatment is basically RASI, anti-RAS, the ACE inhibitor, and ARB. Then your immunosuppression, proteinuria less than 500, you give prednisolone, maybe MMF, and then proteinuria more than 2 gram, you give your IV methylprednisolone, and go on giving it until patient has gone into remission. If patient doesn't go into remission, you can add your other immunosuppressants. Commonly useful over here is your cyclophosphamide. Rarely you do use your CNI, and MMF is a good drug over here. And finally you have rituximab. M3 complement these are drugs like your eculizumab, ravulizumab, and they are useful. And so when patient has gone into remission, taper the prednisolone. In usual case, standard case, you give 1 month, and then you go taper it to 40 milligram. Total dose maybe up to highest 60 alternate day. Then you taper over 6 to 9 months. When you need to have the higher disease control, you may continue it for 12 to 18 months. Maybe solo MMF control is also not bad idea. When you do have prednisolone toxicity, go on giving it. But in small subset of cases, you have RPGN-like presentation. Those cases will do well with cyclophosphamide, IV methylprednisolone, and complement-mediated anti-complement targets like eculizumab. They do well in some of the cases. FACS, plasmapheresis or plasma exchange, may be useful in when the factor is an issue. So apart from that, for the diagnosis, you need to have test for genetics, autoantibody levels, and then you go for the your complement level. So these three are also needed. And finally, exclusion out of the other differentials, secondary GNs is essential.